This is part 2, chapter 19 summary. We'll talk about technical aspects and procedural performance. Then the femoral arterial axis was the standard access site using the Judkins technique. You had to puncture either two ways is optimal. One is using fluoroscopy guidance. You can see it in image B. And the other one was ultrasonographic guidance. Both are pretty good and both reduce risk of complications. In general, you should puncture 1 to 3 centimeters below the inguinal ligament, and don't be misled by patients who are very obese or very thin. So use fluoroscopic guidance or ultrasound. If you insert the catheter wrong, you will get a retroperitoneal hematoma if you are too high. Up to 0.5% of these procedures end up with this hematoma. If you puncture too low, watch out for pseudoaneurysms, AV fistulas, and cannulation of the superficial femoral. Disadvantageous for patients who cannot be too long in bed, have a high bleeding risk, and peripheral artery disease. Okay, if the patient has severe peripheral artery disease, don't leave the wires more than 3 minutes due to the risk of thrombus formation. Here you see the image expanded. Remember to use anesthesia. Remember to use local anesthesia. Remember to puncture at a 30 to 45 degree angle into the common femoral artery. Be sure to be in the common femoral, not below its division. You have to get some solid and pulsatile backflow of blood. This is extremely important. If you do not receive solid and pulsatile backflow, you might be in the vein, you might be in another place, and this might lead to complications. Advance the wire gently. If there's any resistance or pain, define where the wire is. You could have dissected this or perforated it. This is the modified Seldinger technique. There's also the Seldinger technique, which you puncture anterior and posterior walls of the artery and then bring the needle back into the artery lumen. And there's this one, which is modified Seldinger technique. Use whichever you are more feel better with. But in general, if you're learning from zero, try learning with the modified Seldinger. At least the book recommends that. Unfractioned heparin for diagnostic catheterization, only if there's prolonged procedure. Give 2,000 to 3,000 units push. Protamine is not recommended to reverse. If previously on heparin, check out the ACT times. Know the past anatomy or interventions of the patient. For example, if he or she had prosthetic vascular grafts, avoid at all costs passing through them, since this may generate complications as lack of closure and thrombosis. This is the percutaneous radial artery technique. Its popularity has increased. It's much better than the femoral approach if you can use the radial approach. There are some patients where you cannot use the radial approach since you need a larger lumen. You need larger sheaths. For example, in TAVR procedures. As you can see in the image, they are guiding the passage of this needle with ultrasound, seeing the different arteries. You can see the profunda femoral artery. You can see the superficial femoral artery. This means you are too low. You have to go more proximal where you can see the common femoral artery. And look at diagram C. It shows you a line that crosses through the artery. That's nice. That might tell you that's the middle of the transductor of the probe's visualizing field. Remember the Allen or the Barbault test. Allen is more common, but the Barbault test has more accuracy and higher reproducibility. Why? Because you're using an objective parameter, which is oximetry. As you see in figure D, There is no flow of blood after 2 minutes. This means this patient should not undergo transradial CATH. In this section, you can see that for the you have to cover some technical aspects. Put the arm on the board, abduct 30 to 45 degrees with the wrist hyperextended. Use ultrasound if available. Use lidocaine. Be sure to use the anterior wall technique or use the common Seldinger, whichever is best for you. Then don't overstretch the artery with passing different sheaths that are larger than 7 French in males or 5 French in females because it leads to higher occlusion risk. Use hydrophilic and or longer sheaths to reduce vasospasm. Use a bolus of 5,000 units of heparin. Vasospasm prevention through vasodilation. Use nitroglycerin 100 to 200 micrograms push and verapamil 2.5 milligrams. Be sure you have adequate sedation and avoid limb cooling. The radial artery may have tortuosity. It may have an anatomic variant. It may have different changes that may complicate its so be sure to advance the catheter gently. If there's any resistance, see where the tip is. Look for any complications. For example, if you dissect the artery, the procedure can still continue because the catheter serves as a tamponade, but you have to confirm this is resolved when you take out the catheter. You have to intervene if necessary. The inflatable balloon cuff should be inflated 2 cc over bleeding. For radial advantages, it's much better than femoral if you could use any of the 2 techniques in the context of the patient. RCTs have shown the radial axis decreases in 50% mortality and major bleeding, which has been proved. Now, the percutaneous brachial artery technique, use it if you cannot use the other techniques, but this one has the problem that it's similar. It has been replaced by radial and expertise has diminished for most operators. Now we're moving on to venous axis. If the common femoral artery is used, the femoral vein next to it is used most often. Use the femoral artery as a landmark and go 1 centimeter medial and 1 centimeter caudal. Do not mistake venous pulsation from arterial, as in severe tricuspid regurgitation. If you're not using the common femoral artery, then the best approach recommended is the internal jugular over the subclavian due to less pneumothorax. These are the different technical aspects you should consider and use the ultrasound if you can, since it reduces complications 70%, mainly arterial puncture. Remember the anatomic triangle generated by the 2 heads of the sternocleidomastoid with the clavicle. Do not puncture 2 centimeters or less in a proximity closer than 2 centimeters to that clavicle because of the risk of pneumothorax. Now, in the context of patent foramen OVALE cannulation, remember that 20 to 30% of adults have a patent foramen OVALE. Then use a multi-purpose catheter tip directed medially and slightly posterior. Slowly withdraw it, and you'll see it move forward and medial into the foramen. Then prolapse it gently with pressure and confirm its location with blood gases, pressure waveform, and manual injection of contrast. If you cannot do it through this method, use the TRANSSEPTAL catheterization approach, which is described here. It's more difficult technically, and you have to watch out since you have a fillet that it could puncture the left atrium or adjacent structures. This happens only in 1% in experienced sensors with success rates around 90%. For the technical aspects, pause the video. Here you can see on the left the stylet, or on the left is what will puncture the intra-atrial septum, and you have the other catheters involved in this procedure. Now, what about direct transthoracic left ventricular puncture? You don't hear much about it because you can almost always avoid it. You cannot avoid it when you need pressure measurement of the ventricle or ventriculography in the context of mechanical prosthetic mitral and aortic valves. Why? Because you cannot get to the ventricle any other way, and you do not want to pass a catheter across a mechanical valve, for example, tilting disc, where it can get entrapped. If you have the left, then there's two approaches. One is the transapical approach, which is more invasive. You will have to open the intercostal space, exposing the left ventricular apex, and then get there through the Seldinger technique. And there's the other one, which would be with the needle on the locating the apex with echo and moving towards the second intercostal right space. What are the risks? Many: tamponade, hemo, pneumothorax, lacerating anterior descending, embolism of the left ventricular thrombus, vagal reaction, and ventricular arrhythmia. For left heart catheterization, first know what's normal. The normal is the upper row. First, you have to know that you do not want to advance the catheter with the tip pointing at the most distal segment, since you may puncture unwanted structures or create damage. That's why you have to create this six figure, which you will see in the right anterior oblique plane. Then you will push a little, making a U conformation, and with deep inspiration or pullback, the tip will fall into the left ventricle, and you will have your sixth configuration again. For other complex aortas, you have the description right there. Left ventriculography. Echo has reduced its use, but it is still indicated for left ventricular function, BSD quantification of MR. Do not use it in decompensated heart failure or increased risk for contrast-induced nephropathy. For the left ventricle, you use two planes, RAO and LAO. In RAO, you'll see anterior, inferior, and lateral. For LAO, 45 to 60 degrees, you'll see mainly septal and lateral. The main complications are arrhythmia. What about ascending aortography? When will you do this? When you want to see the size of the abdominal aortic aneurysm, when you have to search for dissection, see the severity of aortic regurgitation and the presence of bypass grafts. Use side hole catheters because they reduce risk of creating injury if they have the hole at the tip. What about right heart catheterization? It is central in hemodynamic evaluation. Swan-Ganz is the choice for internal jugular approach. If the patient has hypertension or increased resistances, you can use a variant which is normally known as the pulmonary hypertension swan, which is stiffer and more torqueable. This gives you a more possibility of maneuvering it. Mainly used for femoral approach, pulmonary hypertension, and severe tricuspid regurgitation. Okay, then in general, pass the Swan-Ganz through the right atrium, inflate the balloon, then right ventricle and pulmonary capillary wedge. Okay, and what about the femoral approach, which is technically harder? There's an acute angle from the IVT into the right ventricle. That's why you have to rotate clockwise to point to the RVOT. Watch out, because if you're pointing towards the right ventricular apex, you can perforate it. That's why this shows us the different techniques and how you should advance the catheter. That's all for this, and we will pass on to talk about hemodynamics.